Hello all, welcome to my show Chronicles of a Learner RN, and thank you for listening. My name's Ritika and I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today we'll be talking about cardiac arrhythmias, starting from AF and making our way through to VF. As a disclaimer, I will not be providing any personalised information. All names, numbers and results will be altered to protect the privacy of the patient these stories are derived from. Now, before we get started, I'm just going to try a few new things this episode, just as a warning. If it all goes horribly wrong and this is the worst episode I've produced to date. So, what we're going to do is I'm just going to I've written some dot points as some notes instead of writing a script today. I'm just going to basically just explain it to you like I would explain it to my friends, because you guys are my friends. So let's start with the big daddy of all arrhythmias, and is likely the most common arrhythmia we are likely to find in the community, and that is AF. AF stands for atrial fibrillation. And the way we learnt it in school, I say school, I mean uni, was if you think about your four chambers of the heart, like I discussed last week, you got your two atria, your two ventricles. They go lub and dub. They contract with force, relax. Contract with force, relax. In atrial fibrillation, what happens is that there's so many random pacemaker cells firing all at once that instead of contracting with force like a lub, if you put your fingers out and you just sort of wiggle them around, that is exactly what atrial fibrillation is. I can't do it without showing you, but if you put your fingers out, you go, that's essentially what your atria are doing in atrial fibrillation. There are so many pacemaker cells firing sporadically that random beats make it through to the ventricles. This leads to an irregular heart rate, which is the prime sort of diagnostic criteria, that you don't find a P wave because there's no SA node action. Instead, you'll find a quivering sort of baseline, no distinct P wave, and your QRSs will be grossly irregular. Like, you'll be able to tell that it's irregular without having to map out your R to R intervals like we discussed last week. So, there isn't just one type of atrial fibrillation, there's two types. One's called paroxysmal AF and the other one is, well, just AF. Paroxysmal AF, in essence, is when people usually sit in normal sinus rhythm, but things like stress, caffeine, I've heard even bending down, being upside down can trigger AF, and that's where their heart flicks into an irregular rhythm. Whereas most of the time when they're happy and healthy, their bodies are in a normal sinus rhythm. In these cases, usually people come into hospital with a rapid AF. So about anything above 100 really is rapid AF, but we usually count it above 120. And can be as high as 200, like we discussed in my Scary World of Sepsis Part 2 episode, where a lady came in a RAF of 180 to 200. In these cases, we usually give medications such as beta blockers like metoprolol. These slow down the heart. And we give medications such as digoxin to, one, slow down the heart as well, but to, in essence, revert them back. If medications don't work, so usually we'll give them a chance to work. If metoprolol doesn't work, then we'll go to digoxin. If digoxin doesn't work, then we'll go down the path of cardioversion or DCR. They're used interchangeably. And what we do for this, and this will be like a recurring theme throughout our narrow complex tachycardias, is that we put the defib pads, usually they're not dead, so we have time to sit them forward, put it anterior posterior AP, and we will essentially shock their heart back into a normal rhythm. Now, there are certain criteria people need to meet to be able to sort of be eligible for DCR. One very important one is that they shouldn't have been in this AF rhythm for longer than 48 hours. But I'll discuss that in a little bit when we talk about anticoagulation. So basically, we put the pads on, we sync it up. I'll discuss defib more in SVT as well. No, I won't. I'll just do it now. So basically, yeah, we put the pads on. We, you have to press check sync, or it's called sync, because this lines up with the R waves on the defib machine. And this is very important because if you don't do this, when you press the button to shock, it'll just deliver it straight away. And this can cause what's called an R on R phenomenon and can lead to VF if not careful. So we press check sync. And the difference between checking sync and using normal defib, say in a cardiac arrest, is that you don't just press the electricity button, the one with the little lightning thing on it. You press and you hold, because then it looks for the right time to discharge, and that's what happens. It's as opposed to just discharging straight away, which is very important. And then you've got, but that's paroxysmal AF. We try and get these people back into normal sinus rhythm. Normal AF, though, is just a long-standing AF. These people are in AF all the time. But that doesn't mean they're in rapid AF. So they can have AF just at a normal heart rate, but their heart rate is just irregular. A lot of older people you'll find have this. They'll come in and they'll just be in AF just normally anyway. So symptoms of rapid AF usually include shortness of breath, chest pain, palpitations. But at a normal rate, people with AF may not even feel it. Maybe new onset AF, you might feel some palpitations because obviously your heart rate is, while it's normal, it's going at irregular rhythms, so you may feel that in your chest. But as time goes on, you find people, they just don't notice it anymore. However, when you palpate a radial pulse, you will definitely feel it, because you'll have 2 beats and then nothing, then 1 beat, then nothing. Then you have 3 beats and then a long pause and then another beat. It's very obvious when you palpate when a person's got AF. So let's just talk about anticoagulation, so blood thinning. Why would someone with AF need anticoagulation or blood thinning? If we think about my little bloop before, our atria are not contracting regularly. They're just sort of trickling blood into the ventricles through that little wheelie finger motion that I was describing before. When that happens, not all the blood in the atria is going to go through to the ventricles. Like I said, it's trickling through. In that case, there is blood left behind, and in that stagnant state, it is at a higher risk of clotting. When it does that, then it goes through the ventricles and then it gets shot off through the rest of the body. That can lead to DVTs if it comes from the left ventricle and it's going out to the rest of the body, or it can lead to a stroke if it's going up and into the brain. If it's coming from the right ventricle, a clot, it can lead to a pulmonary embolism, which is a blood clot in the lung, which is a recipe for disaster. So what we do is people usually with, usually it's common in people with normal AF that are in AF all the time, as opposed to paroxysmal AF, because they're in normal sinus rhythm most of the time, unless they're sick or stuff like that. So you'll find people with long-standing AF will be on blood thinners like apixaban or Eliquis, you may have heard of it, or rivaroxaban, Xarelto. Unlikely that people with AF would be on warfarin, because warfarin is usually used for like valve replacements. But I have seen people with AF without valve replacements on warfarin, so it can be a thing. It's just that with warfarin, you have to be very strict with how much you're taking, and you have to get regular blood tests to check how long your blood takes to clot, because if it takes too long, then they'll need to adjust the dose and stuff like that. Whereas with apixaban and rivaroxaban, you just take the same dose every day and you're like fine. So that's essentially atrial fibrillation in a nutshell. Like risk factors for AF obviously include age, previous cardiac conditions like ischemic heart disease, previous heart attacks, high cholesterol, hypertension, increased stress, poor lifestyle habits, stuff like that can all increase your risk for AF. And it's extremely common. I don't know like the numbers for how common, but I'd say like probably 1 in every 4 or 5 people I see in the ED have AF. Like it's that common. So ECG findings, I'll just recap before we move on. We have no P wave, no discernible P wave. We have a quivering isoelectric line. So when we're looking at the ECG, a line that should be straight is usually bouncing all over the place in a very minute manner. This is consistent with multiple pacemaker cells firing sporadically. And then that's what we're seeing on the thingy, instead of one impulse from the SA node making it through to the AB node, which is the P wave PI interval. With AF, because we've got no P wave, we've got no PI interval, and it's very difficult to determine whether they've got heart blocks, which they could, but without a P wave, it's very difficult to see. You're going to have a grossly irregular heart rate. And when I say grossly, you're going to see it. You just look at it and go, yep, that's AF. And use a systematic interpretation to decipher what you're looking at. So if we go through it quickly together, we'll do a rate and you'll see it'll be either rapid or not rapid, whatever. Then you do your regularity. One, you should be able to figure it out, but you can map R to R and it should be pretty off. So that's how you know it's irregular. You got your P wave, you'll write not applicable or you can't find it because there is no P wave. PI interval as well, not applicable or you can't find it. QRS should be narrow because that one impulse is making it through the bundle of his and into the ventricles. So you shouldn't have a wide QRS. And then you should see a T wave because obviously the ventricles are relaxing. And then your QT interval should be okay. Basically in AF, the main things are just P wave and regularity. And that's all you need to know. So we'll move on. We've got SVT. Or in other words, there's another, what's the word? I can't think of the word. Oh my God. Abbreviation. That's the word I'm looking for. It's called AVNRT. So AVNRT stands for AV nodal re-entry tachycardia. And this is sort of the SVT that people think of when they think of SVT. Technically, SVT or supraventricular tachycardia is any tachyarrhythmia that originates from above the bundle of His, because it's, supraventricular. AVNRT and SVT can be used interchangeably. So SVT is a narrow complex tachycardia, usually at above 150 beats per minute. Usually, and this is something that can trip some people up, you won't see P waves the faster the heartbeat gets because it is embedded in the QRS complex. That is why at really high rates, like a RAF of 180 can actually look like SVT. But at this point, clinical history and past medical history will play a role in determining whether it is SVT or a RAF. Usually people as well, like we use sort of both. If we're really not sure, sorry, my thoughts are all over the place. If we're really not sure which one it is, we use sort of the fixes for both and see what works. So we can use metoprolol to see if it comes down, and if it doesn't come down, we can try something else. In SVT, what we really try first is called a Valsalva maneuver. And there's two types. There's a Valsalva and then there's a modified Valsalva. You may have seen this like in TV shows and stuff or people explaining it, but the Valsalva maneuver is just we really want to activate the vagus nerve here in the neck. You'll hear it be called vasovagal syncope sometimes when people stand up too fast or they feel really nauseous and pass out. It's because their blood vessels in the neck sort of expand and allow a drop in blood pressure coming away from the brain, and then that is what causes you to pass out. So we use this to our advantage. Valsalva maneuver aims to engage the vagus nerve to try and shock the body back into a normal heart rhythm in a sort of natural way. So Valsalva maneuver I learnt about this second technique in my ALS study day, but I was taught you get someone to blow on a syringe for as hard as they can, and I'm meaning hard, for about 10 seconds or 15 seconds until they're about blue in the face, and then that's it. Hopefully that sort of activates the vagus nerve and gets them going. But like a little spoiler alert, usually it doesn't. So then we move on to what's called the modified Valsalva, where we'll tilt sort of the bed. This is how I saw it back when I was a student. We tilt the bed backwards, but we get the patient to sit up. So if you think about a bed tilting towards the floor and then they're, actively using their abs to sit up, we do the same thing. We get them to blow on a syringe as hard as they can for about 15 seconds. And then what we do, you need two people for this, grab them by their legs and flip them upside down. It sort of just shocks them back into a normal rhythm. Sometimes it doesn't work as well. For babies, a Valsalva maneuver, so if you've got, because babies can get SVT as well, children, what you do is instead of getting them to blow into a syringe, because usually they can't listen to instructions, what you do is you pop, without them knowing, you pop their face into ice cold water for about, I think, 5 seconds. And that essentially shocks the body in a natural way. So if your Valsalva doesn't work, then we move on to chemical fixes, chemical techniques. Yeah, techniques is a good word. So we use a medication called adenosine. Now, I'm sure there's so many people on TikTok, on the internet, that talk about adenosine and how it works, how you should give it, blah, blah, blah. So basically, adenosine is an AV, I've got it written here. It's a transient AV node blocker. Basically, it blocks the AV node from any impulses getting through, and it just sort of shuts down the heart for a few seconds, and then restarts, and we aim to restart in normal sinus rhythm. Obviously, usually this doesn't work as well. But what we do is we start with a dose of 6 milligrams, then we move on to a dose of 12 milligrams, and then we do a third dose of another 12 milligrams. I think it's to make 30 milligrams total. This is the way we do it. Obviously, everybody's told you on the internet that adenosine has a really fast half-life. I think it's only a few seconds. So once you push it in, you need a 20 ml flush immediately afterwards, like slam, slam. And then you'll see some old school doctors lift up their arm above the head in an effort to get it to the heart faster. Because if you don't push it in fast enough, it's just not going to work. And that's an adenosine dose wasted because you can't do that again. You'll have to move on to the next one. You'll also see that patients that have experienced this usually align adenosine with an impending feeling of doom. This is because they are essentially awake when their heart is stopping. Because when your heart stops, you'd usually be unconscious. So it is quite a scary thing. So for patients, I find with patients that have had it before, they usually need some sort of benzodiazepine to calm them down before doing it again, because that's just how scary it can be. If that doesn't work, then we can go down the DCR route as well. Like I discussed with RAF, you put on your pads, you turn on sync, and then we go again, essentially. So I've got 2 stories for this sort of arrhythmia. Recently, we had a lady come into resus. She was an SVT in the 200s. She had a history of SVT, so that's how we knew. AV had already tried 2 lots of Valsalva maneuvers and a modified Valsalva. And then they did 6 milligrams of adenosine, and then I think they did a 12 as well. So we did another 12 that didn't work. And then I went home, so I'm not exactly sure how we reverted her back. They may have DCR'd her. But then I came back the next day, and of course she was still in the department because we're terribly bed blocked. And she was fine. And then I hear a Met call on her, and she's gone back into SVT. But I didn't look after her that day either, so I don't know what they did to fix that, because I don't think she came to resus. But my own patient, I had a patient in the monitors. I think she had sepsis. She was on the cardiac monitoring. Luckily, I had her on the full 12 lead, because just out of the blue, I'm sitting at the computer and I hear the alarm go off, and like the red do 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 alarm, and I'm looking at it, and her heart rate's now in the 180s, and it says SVT, and I went in and I printed an ECG in less than 30 seconds, and that's like the fastest I've ever done an ECG. Is because I had all the leads on her already. So I called a Met call on her as well because she was under Gen Med, and basically the Gen Med doctor came in. She wasn't really listening to instructions, so we couldn't do a proper Valsalva or modified Valsalva. So what the sorry, I'm just looking it up. What the Gen Med doctor did is called a carotid sinus massage. It's like the Valsalva in the sense that we try to activate like the vagus nerve and try and cause some vasodilation. But the way we do it is we basically just massage the carotid artery. It was the first time I'd ever seen that, actually. So I was like, whoa, it's like magic, because I was looking at the monitor and her heart rate just dropped back to normal. But I've been told since that it's not really something we should do anymore. I think studies are showing that it's quite risky because it increases the risk for clots. Like if they've had blood clots before or if they've got some sort of condition, it's usually contraindicated. But yeah, like it was very cool. But that's SVT. If you want more information on carotid sinus massages or SVT or vagal maneuvers, just let me know. Next on our sort of long list of arrhythmias is we've got another AF. However, this AF is a different AF. We classify it with a capital A and a lowercase f, and it stands for atrial flutter. This is another narrow complex tachycardia, but it's got some very big differences between atrial fibrillation and atrial flutter. Atrial flutter is essentially, instead of multiple pacemaker cells firing all sporadically, this is one pacemaker cell that close to the SA node but isn't the SA node, firing off over and over again at a very, very fast rate. Atrial rate usually is 300 beats per minute. So it's going at 300 beats per minute. The impulse is firing at the AV node, but only 1 in 2 or 1 in 3 or 1 in 4 of those is getting through. This is what brings our QRSs sort of further apart. And then, and that is why it's a narrow complex tachycardia, because one is going through. So say we've got, we call it a 2-to-1 atrial flutter, or a 3-to-1 or a 4-to-1. If we've got a 2-to-1 atrial flutter and we think about our atrial rate as 300 beats per minute, 2-to-1, you'll see a heart rate on the monitor as 150, because only every 2 beats a QRS is getting through. 3-to-1 AF would be 100 beats per minute, because 1 in every 3 beats is going through. And 4-to-1 atrial flutter would be, you'd see 75 beats per minute for the same thing. Another diagnostic factor or indication for atrial flutter is what's called a sawtooth P wave. So in atrial fibrillation, we've got a quivering baseline, can't really see a P wave because everything's going off at once. In atrial flutter, you'd see a very distinct sawtooth-like pattern. It's like slanted on an angle and quite pointed. And you'd see that, say you've got a 3-to-1, you'd see 1, 2, 3 QRS, 1, 2, 3 QRS. If you've got a 4-to-1, you'd see 1, 2, 3, 4 QRS, 1, 2, 3, 4 QRS. The longer it is, or the more beats getting through, the less beats getting through, the more the sawtooth pattern becomes apparent. And another key difference between atrial flutter and atrial fibrillation is that in atrial flutter, the rhythm is regular, because every 1 in 4 beats is getting through. That's why your heart rate stays at 75. It's usually extremely regular. Like usually we'd have some differences here and there depending on when we move and stuff like that. In atrial flutter, it's likely to stay the same. You'd see just 75. To fix atrial flutter, we usually use antiarrhythmics like amiodarone to sort of reset the rhythm. So amiodarone is a potassium channel blocker. Now, I don't expect you guys to know all the different cardiac channel blockers and stuff like that, but basically there's 4 classes. You've got your sodium channel blockers, your beta blockers, which is your metoprolol and stuff like that. Then you've got your potassium channel blockers, and then your calcium channel blockers. So sodium channel blockers include medications like flecainide or lignocaine. Like the anesthetic lignocaine has very weak sodium channel blocking properties, which is why you can give it in some arrest situations, but that's a bit too advanced for today. Beta blockers, metoprolol like we know, potassium channel blockers, amiodarone, sotalol is a potassium channel blocker, not a beta blocker, even though it's got a lol. And calcium channel blockers include amlodipine and stuff like that. Yeah, I think that's right. I'm doing this off the top of my head. So yeah, we give amiodarone, which is a potassium channel blocker. What it does is it increases the time it takes for the ventricles to fully relax before the atria sort of kick in and try and disrupt the rhythm that way. But if the patient is hemodynamically unstable, then we can do DCR. My story on this one is that we had a man that was in an atrial flutter of about 135 beats per minute. So it was like between 3 and 2. So every beat would have either 2 or 3 sawtooth patterns. And in this case, I can't remember too well off the top of my head, but I think we were about to give amiodarone. Or maybe we did give amiodarone and he reverted back into sinus rhythm. And that was the day I think I asked why we give amiodarone instead of metoprolol for atrial flutter. And that's the day we went into depth about AV nodal re-entry tachycardias and re-entry circuit tachycardias. And basically the way you sort of think about it is that this one pacemaker cell is going to the AV node, and instead of going down the channel through the bundle of his bundle branches, Purkinje fibers and blah, 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 the beats that are missing are taking a shortcut back to that pacemaker cell and going again. Taking the shortcut, going again. Taking the shortcut, making it through. Go again, taking the shortcut. And this is going at 300 beats per minute. Much faster than I'm doing it. But that's basically how a re-entry circuit tachycardia works. So you need to really just stop that pathway. So this is where you'd find people that get ablations. This is where they go and cauterize certain spots where they find that the circuit is going through. So if you're getting atrial flutter or SVT pretty commonly, then yeah, ablation is where you'd be heading if it's really common. Junctional escape rhythms are next, and I've written here, it was a tough one for me to wrap my head around. It took me almost 2 years, and that is very true. Junctional escape rhythms or junctional rhythms are when I explain it, it doesn't seem complex, but at the time it was very complex because I think the people that were explaining it to me weren't explaining it very well. But basically the impulse generates near or within the AV node as opposed to the SA node. And because of that, you'll find that the P wave is inverted, and either inverted before the QRS, inverted within the QRS, so you won't see it, or inverted and just after the QRS. You won't see this rhythm often, so don't really worry about it. But there's a few different names for the rhythms. Junctional bradycardia is less than 40 beats per minute. Junctional escape rhythms are 40 to 60 beats per minute. Accelerated junctional rhythms are 60 to 100 beats per minute. And junctional tachycardia is above 100, obviously. Usually people are asymptomatic of this unless they're either low heart rate, high heart rate. And it's usually caused by pharmacological agents like digoxin toxicity and what we call beta agonists like isoprenaline, and AV node blocking agents, and of course electrolytes, because a lot of this can be caused by electrolytes. Now I'm running out of time because I got to go to work, but let's quickly run through VT and ventricular escape rhythms. So ventricular escape rhythms are basically impulses that generate from the ventricles. Your ventricular pace is 20 to 40 beats per minute, but sometimes this can sort of outwork the SA node. So if it's coming from the ventricles, you'll see it'll have a wide QRS and P waves will be absent, because obviously if the SA node is, especially in VT, the SA node is not conducting the electricity, you're not going to see a P wave. You're just going to see the really wide QRS. So what we call the ventricular pacemaker, or the ventricular pace 20 to 40, sometimes that can outdo the SA node, like I just said. These are called premature ventricular contractions, or PVCs, or we call them ectopics. Once every few beats is fine, or sporadically is fine. You may feel some palpitations, but usually it just goes away, or you won't even feel it, you won't even notice it. It's when this is happening over and over again, so more than 3 beats in a row, this is when we start to call it its own rhythm. So ventricular escape rhythm is usually 20 to 40 beats per minute, or the criteria is less than 50 beats per minute. Between 50 and 100 beats per minute, if you're getting just these PVCs over and over again at a rate of 50 to 110, this is called accelerated idioventricular rhythm. So your ventricular pacemakers are firing faster than the SA node, leading to multiple ectopics, or premature ventricular contractions. And then it's only called ventricular tachycardia once it hits a heart rate above 110. And you'll see on the ECG that it's just essentially just waves. There's no P waves, there's no T wave. It's just a huge QRS. Not even a QRS, it's just a large R wave just going up, down, up, down, up, down. You can have conscious and unconscious VT. So basically, it's pretty self-explanatory. If your cardiac output is so low that it's causing hemodynamic instability, then you'd be unconscious, and that's what we call unconscious VT. And that's when we'd start running through the ALS algorithm. Conscious VT, it means your heart is compensating well and you can be conscious. In this case, we'd use medications like amiodarone, like the antiarrhythmics, to sort of sort your heart out, really. You may hear, we call it runs of VT sometimes, where you're flicking in and out of VT. Means that at this fast rate, we're seeing maybe 5-10 seconds of VT and then it goes back. For this, we use medications like amiodarone to really stop that from happening. So next on our list of arrhythmias is a pretty funky one. So it's called polymorphic VT, or another name for it is torsades de pointes. Now, I'm very sure this is not how you say this, but it's a type of ventricular tachycardia VT. Polymorphic means that it changes amplitude. So I don't really know how to describe this without you seeing it. So I highly recommend, even for all of the previous arrhythmias that I've mentioned, just go and Google it to see what it actually looks like. But basically, the best way to describe it is the size of the VT waves sort of shifts. It'll go from very large looking waves to very almost ventricular fibrillation type looking waves, but they'll be a bit more pronounced and they'll go back to being large, and then they oscillate between large amplitude and small amplitude. So it's technically a VT, but it's a bit more alarming and it's treated differently to VT. This rhythm usually occurs through, you may remember it from last week's episode, we talked about QT intervals and how they're important because they can lead to certain arrhythmias. So prolonged QT intervals cause torsades de pointes, or polymorphic VT, because the length from the time the ventricles start depolarizing to the time they repolarize, if that's too long, then it doesn't leave enough time for the heart to stop before the cycle begins again. And that can cause, fatal arrhythmias. So like I said before, we treat torsades a bit differently. Instead of giving antiarrhythmics, we give magnesium. To be frank though, I don't really know why. While I keep talking, I'm gonna look that up. So yeah, when you see someone with a fluctuating VT, you should be very worried and try and get them out of that rhythm as soon as possible, because if you don't, then they will, well, you get the point. So I've just Googled it here. Magnesium sulfate is first-line treatment for TTP, a specific type of polymorphic ventricular tachycardia often associated with QT prolongation. Intravenous magnesium sulfate helps stabilize the cardiac membrane, we already know that, and can effectively terminate the arrhythmia. Okay, so it affects the potassium and calcium movement across the cell membranes, so like the action potential, and it helps that way. Now, I know my series is like a for dummies sort of platform, so everything about the potassium channel blockers and all that amiodarone, the action potential and cell membranes, don't worry about any of it. Just remember that VT we treat with amiodarone, and torsades de pointes we treat with intravenous magnesium. So, like I said, why is it so dangerous? Because it can segue into VF. Well, it doesn't really segue, but yeah, untreated torsades de pointes goes into VF. So let's talk about VF. VF, if we think about AF and how the atria sort of quiver a little bit, in VF the ventricles are doing the same thing. However, it's a bit more important in the ventricles because if they are not contracting with force, the entire body is not being perfused, whereas in atrial fibrillation, there's still blood going through the valves into the ventricles. Minute, but there still is. And the ventricles are still contracting normally to pump blood to the rest of the body. But in VF, this is not happening. So when you've got someone with VF, they've essentially got no cardiac output. This leads to basically poor outcomes. If you see someone in VF, so on the ECG, you'd see nothing. You'd see like your quivering P wave, but with no QRS. It'd just be some squiggly lines that you can't interpret. There'd be no P wave, no PI interval, no QRS, nothing. So if you see that on an ECG, I'd be pressing the emergency buzzer and starting down what first would be going to BLS path. So do your doctor's ABCD, start compressions. And then when the ALS certified crew come, we'd be going down the shockable path of the ALS algorithm. So we'd be going, 200 joule shock, then another round of CPR, then adrenaline and shock, and so on and so forth. We've discussed this before. Medications we give for VF is basically just the adrenaline and the amiodarone as per the shockable pathway of the ALS algorithm. Nothing really more we give specifically for VF, but in this case we would be wondering what the cause of the VF was, whether it was cardiogenic shock or whatever it could be, obstructive shock, maybe a PE, because yeah, it's one thing to get someone back from a VF arrest. Actually, I have a story about this one. We had a young dude come in, probably in his 40s. He ended up having a VF arrest. I think he was playing basketball. And after the game, he was feeling some chest pain. So he drove himself into ED, and he was at the triage desk, mid-triage, and he collapsed. And yeah, he was in a VF arrest. I got to meet him probably about a week afterwards, maybe just less than a week afterwards. He stayed in hospital for about 2 days afterwards. He had, I think it was a STEMI, and that is what caused the VF arrest. He had a heart attack that went into cardiac arrest, like I talked about last week. But he only stayed, took him to cath lab, reperfused his heart, and he was out 2 days later. But yeah, VF is one thing to get them back from it. It's another thing to find out what caused the VF and fix that. So that's all for our sort of specific arrhythmias. As I mentioned last week as well, we'll talk quickly about the Tachy-Brady algorithms. So there are two ALS algorithms that we use in conjunction with the regular stock standard ALS algorithm. So we'll talk about Tachy first. I've got these. I wrote these down off by memory and then put them up on my wall, so I've got them right next to me. But the tachycardia algorithm, you start off with a question. Is the patient stable? And by stable, we mean, is their blood pressure above 90? Are they GCS 15? Have they got chest pain? Have they got heart failure? So then you go down two routes. We'll talk about unstable first. So if their BP is less than 90, they've got chest pain, or they're looking a bit altered conscious state, we go down the unstable route. This is when we talk about sync DC shock. So we've already discussed this through DCR. The difference between sync DC shock and DCR is that DCR is we're doing for a stable person, that we can have them awake and we sedate them for a little bit and then we shock, and then we'll get into a good rhythm and then we'll come out. Sync DC shocking is, well, they're already sort of in an altered conscious state. So we can shock up to 3 times. And if that doesn't work, we give 300 milligrams of amiodarone over 10 to 20 minutes. So faster than we usually do. We shock again. And then we give a continuous infusion of amiodarone 900 milligrams over 24 hours. But this 900 milligrams over 24 hours is usually split up into 450 milligrams over 12 hours, reassess, and then another 450 milligrams over 12 hours. This sync DC shock in an unstable patient usually is a matter of urgency. I've heard 4 VFRS before, and it's actually on Life in the Fast Lane as well, shockable VF, shockable arrests, that if you witness the arrest, the moment they go into the arrest and you can get the pads on in less than a minute, you can shock them 1, 2, 3, just bang, bang, bang. And that has a higher likelihood than of getting them out of the rhythm than starting CPR, getting the pads on, and then going that way. It's just something to think about. So let's talk about the stable route. There's a bit more going on in the stable route. We'll have to narrow down sort of what tachyarrhythmia we're looking at, and then sort of decide what treatment we choose based on which arrhythmia it is, because as we've discussed today, all of them are very different. So it's very important that we know which one we're dealing with. So when we're going down the stable route, we think about, is the QRS complex narrow? Whether the source is above the ventricles or within the ventricles. So let's go above the ventricles first. So let's say they're narrow. Then the next question is it regular? So under regular, we've got SVT, and under irregular, we've got AF. We already know what to do with those. SVT, you do your vagal maneuvers, you give your adenosine. In AF, you give your beta blockers, your digoxin, your DCR if you need to. The thing is, after adenosine for SVT, if there's still no sinus rhythm, that is when you think about, oh, is this possibly a fast atrial flutter? And at that point, you need to think about rate control instead of changing the rhythm. If we think about broad QRS complexes, we go regular, irregular again. Regular, we're thinking VF, oh my God, VT. We do the amiodarone like we discussed. There's actually another regular, broad, complex tachyarrhythmia that I didn't mention because it's quite weird. It's called SVT with aberrancy. And what happens is that it sort of looks like VT, but how do I explain this? It sort of looks like VT, but your axis is wrong and you've got a bundle branch block. It's very, very complex, and we're not going to talk about it today. But that's another broad, complex, regular rhythm. And then we move on to irregular. And you can have AF with a bundle branch block, which would make it a broad, complex tachycardia because bundle branch blocks are make the QRS quite broad. And then obviously your torsades is an irregular rhythm. Well, they all look sort of regular, but it is an irregular rhythm. And for that, you give magnesium. And then maybe I'll just recap it again, just in case anybody's forgotten how the coached approach works. So if we had to DCR someone or cardiovert someone or sync DC shock, whatever you want to call it, we go through the coached approach to make sure nobody gets hurt, because there have been many times where people do get hurt. So you put your pads on, the patient is either out of it or sedated, and we get started. They've got pre-oxygenation on through the Hudson mask, and we're ready to go. So we start with the C. In this case, it's not compressions continue because we're not doing compressions. We can substitute it for check sync. So this is the time that you look at the defib, press the sync button, and you should see little hats over every QRS, every R wave. O is for oxygen away. It's very important. The second last time I did a coached approach, and it was like a junior doctor doing it. She wasn't looking at the patient. She was looking behind her at the coached approach on the wall, and she couldn't see that nobody had taken the oxygen away, even after she had said oxygen away. And she moved so fast that they had to, I kid you not, they had to like rip the face mask off the dude's face and like fling it away because she was like getting ready to shock. So very important. Look at your patient, make sure the oxygen is actually away. A is all else clear, so make sure everybody that doesn't need to touch the patient is away, top, middle, bottom. C is charging, so at this point you will check with the doctor, make sure. With ALS, it's very simple what joulage to choose, but in DCR it's sort of, there's no really set number on what to start with. So some people will start with 100, some people go straight to 200. So make sure you discuss that with the doctor before we start this. But you charge to whatever joulage was set. And then we do hands off again, just a final check that no one is touching the bed or the patient. We'll evaluate the rhythm, make sure they are still in this tachyarrhythmia. And then discharge. Press and hold the button to make sure, well, obviously if you press it, it's not going to discharge, but you press and hold to make sure that it delivers at the right time and you don't cause them to go into VF, because we don't want that. But that's the tachyarrhythmia algorithm. Well, quickly, I realize I have been rambling for an extremely long time. So we're just going to quickly go through the Brady. Basically, it's a similar premise. Instead of are they stable, it's I do see adverse signs. Adverse signs meaning BP less than 90, heart rate less than 40, ventricular arrhythmias, or if they've got a history of heart failure. We'll go through no because that's quickest. If they don't have any of these, then monitor them. Think about their risk of asystole. If they've had a recent asystole, so they've just come back, or ROSC, and they've got a low heart rate. If they've got a type 2 heart block, second degree heart block type 2, so a Mobitz type 2, which is the one where the PR interval is prolonged but stays the same, and then the beat gets dropped. If they've got a third degree heart block with a wide QRS, or if they've got a ventricular pause greater than 3 seconds, then we'd be thinking about moving over to the yes category. If they have none of these, then you just observe them, and you shouldn't really be using the bradycardia algorithm anyway, because they're probably fine. But if we go down the yes column, basically it tells you to give atropine 500 to 600 micrograms IV push. It comes in about 3 ml. It says 500 to 600 because some ampules come in 500 and some come in 600. At my particular hospital, they come in 600. So this 500 micrograms is nonsense. We just give the 600. If they have a satisfactory response after this, we go over to that risk of asystole question and we observe because they're fine. But this is unlikely to be the case. And then if there is no satisfactory response, we try it another 3 times. I take that back. Another 5 times to make a total of 3 milligrams. And these are all IV pushes, giving it about 1 to 2 minutes to work in between. And then going back to that risk of asystole question, if they do have a risk of asystole based on the criteria I just talked about, then we go back over and we do the extra atropine. Another thing we can do is we can start an adrenaline infusion. This will act on the beta receptors, beta adrenergic receptors in the heart, increase contractility as well as increasing heart rate. We can do alternate drugs, so like isoprenaline I mentioned before. It's a beta agonist, meaning it works on the beta receptors, increasing heart rate and contractility. There's other drugs here I've listed: aminophylline, dopamine, glucagon, glycopyrrolate. I know what these drugs do, but to be completely honest, I don't know what they do in this sense. So I'm not really going to talk about them today. But then if these stop working, or they're having too many unwanted side effects, because with adrenaline as well, increased heart rate will increase the blood pressure as well, because it's going to peripherally vasoconstrict. The next thing you can do is called transcutaneous pacing. I think I spoke about this last week. I can't really remember. But like with your DC shock, you're going to put the pads on, AP, and instead of pressing the sync button, there's a pacer button. You press that and it'll start mapping out the R waves, same as when you do with sync. But in this case, you're going to set the rate. So usually we set a starting rate of 70 beats per minute. And what you do is you turn up the amperage slowly until you can see that the machine is pacing. And what that means is it's sending an impulse to the heart, which is generating a contraction. What this looks like on the machine is this straight line, so called a pacing spike, and then a wide QRS because it's working on the ventricles. And it's not a full sort of thingy, it's just a ventricular contraction. This is what's called electrical capture. I think I did talk about this because I remember talking about electrical capture. And when you see electrical capture, you'd want to see mechanical capture too, which is like miniature twitching from at least the chest, maybe even the whole body. As well as, you'd see an increase in heart rate on the defib, but you'd want to see an increase in heart rate on the monitor. You want to feel an increase palpable heart rates. That also comes under the banner of mechanical capture. And you should see that the patient starts to become more alert. Their blood pressure comes up. They start to feel a lot better. That being said, you do sedate people for this, so give and take. It's a case by case basis. So yeah, like I said before, I have rambled an extreme amount this episode. If you've made it this far, thank you very much. I'll tell you what I did differently today. I basically did not write a script. I've written some dot points and I'm going directly off of my frontal lobe knowledge, what is readily available to me at the moment. Apart from that magnesium for torsades thing, I know magnesium helps stabilize cardiac membranes, but I didn't think that's what we were doing in torsades. But that's fine. So yeah, if you've made it this far, thank you for listening. 1, 2, please let me know if you'd like this sort of format, if you'd like my previous formats where I was sort of just reading from a script. One, I was kept to time because I wasn't rambling, but I want to know if this way I sort of am treating you like a friend, just explaining it to you like I would a friend, or whether either way was the same and I've just wasted a lot of your time with this one. Let me know. So I'm gonna read my wrap-up spiel, but yeah, please, I'd appreciate the feedback. Yeah. Anyway, this wraps up this episode of my show, Chronicles of a Learner RN. I certainly have learnt a lot, and I hope you have too. I have a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you, and see you next time.